Now, moving on to our first section, that is the injuries of the hand, which include the metacarpal shaft fractures. As you know, the hand actually starts at the wrist joint, but they are mainly wrist joint is made up of distal radius, ulna, and the carpal bones, which are actually separate entities. The hand mainly starts from the metacarpals, and the metacarpals involve different anatomical structures, which involves head, neck, shaft, and the base. In this section, we will be discussing the metacarpal shaft fractures. First, we'll be going through briefly the general principles of the treatment in hand injuries. Then we'll going through the fractures of the metacarpal shaft, what is their classification and how to manage them. And lastly, we'll briefly going through the treatment of metacarpal shaft fractures. It's very common. Usually, there's fall on the outstretched hand, or there's blow to the head, or usually during a punch, or during a fight, or during boxing, there can be injuries of the metacarpal. So, and it's very common. Usually, at least three views. Why? In most of the orthopedic, it's always the two views, the AP and the lateral. But in hand, sometimes you need an oblique view as well, just to see the angulation and how much rotation of the segment is there or not. Superficial injuries can be very obvious. Superficial fractures could be very obvious. There could be extremely tender at the point. And if there is a skin damage, for example, if there is a cross open injury, then one must be very careful is that the patient must be examined in a clean environment. Why? You don't want to further contaminate the hand, which is a very important and vital structure. With the hand displayed on the sterile drapes. Why? Because when we are examining what the extent of neurovascular damage or how much the fracture is, it must be done in a sterile environment. Otherwise, there are chances that already it's very contaminated wound. There's increased chances of contamination leading to osteomyelitis, severe necrotizing fasciitis, or even the compartment syndrome in case of the hand. So the general principle of treatment actually includes we have to deal with certain things first. Before we deal with the bone fractures, there are certain other things which are far more important in hand than the bone fracture itself, which is one of them is circulation. We may need a direct repair or even a vein graft may be required as well. Then we have to think of the swelling as well, because swelling may lead to eventually compartment syndrome. So generally the hand injuries when there are metacarpal fractures usually elevated, and early and repeated active exercises are actually started so that the compartment syndrome can be avoided. Third is the splintage. Now in hand, usually surgery is less commonly done, although we can do plating and screw fixations to metacarpals and different phalangeal fractures. But usually for most of the fractures, they're usually done conservatively, and that is by a form of a splintage. So it's important what is the position of safety and what is the safe immobilization, so that we can later on give a good functional recovery for the patient. Internal fixation in some cases is required, but then if that is done, that has to be done under meticulous aseptic conditions. Skin cover is important. Bone exposed, tendon exposed will usually die out. So we have to make it sure that the bone and tendons are not exposed. And the last is the nerve under the tendon injury. There are some, especially the tendons, which is something which is very important in the hand because they are the part of the functional aspect of the hand. So sometimes the bone injury is not that much of a concern. Rather, what the most important concern is actually the tendon injury, which may be flexor extensor tendon injuries. Sometimes the primary repair is done, or occasionally the grafts may be required depending upon what is the size of loss of the tendon which has occurred. Now, finger metacarpal fractures. As you know, metacarpal bones are vulnerable to blows, which could be direct, which could taken on the hand, or falls upon the hand, or this could be longitudinal fractures of the boxer's punch. Usually, this can occur during the boxing, or it could be when occur during a street fight as well. And when a person punches the hand into a hard surface, this can lead to a metacarpal fracture. Where can metacarpals get fractured? They can involve either the head, the neck, or through the shaft, or even through the base as well, which is important which area of the metacarpal has got involved. Now what's important over here is that we need to remember that there is a longitudinal angulation, that is in medial lateral plane, then is rotational angulation. Angular deformity is not very marked and it's not of a problem, but rotational deformity is serious, because later on if fingers would be rotated in a different plane, that will seriously hamper the hand function. So if fourth and fifth metacarpals, they are actually more commonly injured. Why? Because they are more mobile at their bases, and the good part is they're able to compensate for the residual angular deformity. So in almost fourth and fifth metacarpal, up to 45 degree of angular deformity is acceptable. But if you come on the first or second, usually, let's say it's almost 15 to 30 degrees. It's not more than that. It's acceptable. The reason it's that the fourth and fifth are more mobile, while the first and second metacarpal are relatively more rigid. Fractures of thumb metacarpal, they usually occur at the base, and we'll be discussing the details of Rolando and Bennett fracture in the third section. So, how can fractures of the metacarpal shaft? If you see, this is the metacarpal, this is the head, this would be the neck area, this hole is the shaft, and this forms the base of the metacarpal. The most commonly part injured is always the shaft of the metacarpal, and they can occur due to always this is called as twisting and punching force, due to which can result in a spiral fracture or a boxus fracture, which may be characterized by local pain and swelling, and sometimes a dorsal hump may be present as well because the fractured segment is displaced upward. Coming to the treatment, oblique or transverse fractures with slight displacement, depending upon what is the angular deformity and what is the rotational deformity. The rotational deformity is not very much acceptable, but angular deformity can be accepted. So if there is slight displacement, you can simply don't need the reduction as well. That will heal on its own. And splintage is also unnecessary. We can go for crepe bandage, but sometimes the splint is usually given just in case. Although firm crepe bandage is maybe more than enough. And then after 2 to 3 weeks, we start active range of motion, and usually this callus is found in 4 to 5 weeks. By this, we can remove the crepe or splint as well, and then we can continue with the patients with the further rehab. Now coming to the transverse fracture with a greater displacement. If it is displaced or angulated or rotationally malformed, then we may require first the reduction, and then we may require the splint as well. And usually is reduced by traction and pressure. That is very simple. If the distal segment is dorsally displaced, we know we have to move it molarly. So the force is applied from the dorsal surface toward the volar surface. If it is volarly displaced, then we have to apply the force during the traction from the volar surface toward the dorsal surface. That is always the opposite of the injury which has occurred. Held in a plaster cast, and usually this is the normal mechanism is that the metacarpal heads are spared, and so that the fingers can easily move. Carpometacarpal joint is spared, and slight extension of the wrist joint, and sometimes you have to go up till the a radial head, or sometimes the elbow may have to taken in as well, but usually elbow is spared because of the one joint above is actually the wrist joint, and one joint below is actually the metacarpal phalangeal joint. So that theory of one joint above and one joint below should be 3-point fixation is still in the play, but as the fracture is over here, so you don't need to go apply a splint above elbows. Even the below elbow would be suffice, because if the fracture is in the shaft over here, then the joint below is metacarpal phalangeal joint and above is actually carpometacarpal joint. Sometimes it requires surgical fixation, which could be metacarpal plates are now very readily available. Although they are mini fragment plates, they can be applied, but usually not required. Most of the time, conservatively, if we do want to go for surgery, we can go for simply 2 cross K wires. And 2 K wires are used so that the angulation can be prevented and rotational deformity can be prevented. And that's it. And then you apply a cast of 3 to 4 weeks for at least this time. If it is spiral fracture, that means usually, if for example, if this is the kind of a fracture, it's a long spiral fracture, these can be still be liable to rotate, so can be managed non-operatively as with the apply of the plaster and splint for 3 to 4 weeks. Sometimes they can be fixed depending with the lag screw. Lag screw principle actually is that the screw is applied at perpendicular to the orientation of the fracture line. If the fracture line is in this plane, you apply a screw at 90 degrees to this fracture line, as you can be appreciated over here. Now in this orientation of the fracture line is this, that's where this applied screw in this direction. So that is lag screw can be applied, or even the percutaneous K wires can be used as well, which can be shown over here as well. For most of the time 2 are enough, but sometimes maybe a 3 is needed as well. And usually then we can once we apply the K-wire, and we can plaster it for 4 to 5 weeks, and once we remove the plaster, we can start active assisted range of motions exercises, and eventually the rehab can be started. In this section, we have briefly gone through the general principles of the management of the hand injuries. We have to be very meticulous about the injuries of the hand and their assessment, especially if it's open. It has to be examined in a sterile environment so that we further do not contaminate it. As far as the metacarpal shaft fractures are concerned, most of it are actually managed conservatively, either in form of a crepe bandage or even some form of splint can be given. If a plaster cast is applied, that is usually applied for 4 to 5 weeks, and in such a way that it is applied below elbow and the metacarpal heads are actually spared, so that metacarpal phalangeal joint is mobile. For most of the fractures, that would be enough. But if open adduction tunnel fixation is needed, nowadays readily available percutaneous plates are available, but even then they are not readily utilized. Only the K wires are more than enough to go for reduction and fixation of the displaced metacarpal shaft fracture. Thank you very much. Keep watching sqadia.com.